Hello to everyone, my name is Giacomo Fabbri from Italy, and this lecture that I prepare for Guide Dental Education is aiming to describe the influence of the modern clinical strategies on the integration and on the reliability of the prosthetic outcome. We will start speaking about the materials. In fact, today the clinicians have at disposal a lot of materials that really has revolutionized the traditional prosthetic approaches. We can see that all the new metal-free material can be divided in two big families. The first one is the silica-based ceramics. These materials are characterized by main features like the etchability, like the translucency, like the low flexural strength, and like the possibility to use the bonding technique with this approach, and so the possibility to cement this restoration with an adhesive approach. The other family is the high-strength ceramics. High-strength ceramics are characterized by a high flexural strength, a high opacity, and no etchability. And they represent really two completely different worlds that must be treated also really different from the clinical and the technical point of view. To give you some examples, for example, the silica-based ceramics are really useful in case of the treatment of the anterior segments. Like, for example, in this case, when we treat this central incisor with the silica-based ceramics, we're creating a perfect integration, a perfect natural appearance, and obtaining a wonderful aesthetic outcome thanks to the translucency and thanks to, of course, also the ability of the dental technician. The silica-based ceramics are absolutely the best choice also for veneers, for example. We can see this case where we perform a multidisciplinary approach with an orthodontic therapy, a minimal orthodontic therapy with Invisalign that's allowed to me to move the teeth in the right position in order to minimize my preparation. These are the preparation of this case where really I preserve a lot of enamel to all the teeth that I prep, and these are the final outcome that I achieve with this material thanks to the high translucency and thanks to the possibility to etch this material, and it means that I don't need retentive preparation on my element. Thanks to the adhesion, thanks to the bonding approach. And here we can compare the result in the end of the treatment, and now we have the result before our treatment. So, the silica-based ceramics also are really useful when we want to work with really minimal thickness, like in this case where we treat the canine with the veneer with a small thickness in order to manage this problem of an abrasion on the vestibular portion of the tooth, maintaining enamel as much as possible. And this is the result after the cementation and after several years after the delivery. So these are the silica-based ceramics. What about the high-strength ceramics? High-strength ceramics are really important to use when we need support, when we need the framework support for our rehabilitation. Like in this case, where we treat, for example, the anterior segment in the lower jaw with the bridges from canine to canine. And I love this image because I want that you pay attention on the arrow. Look where I position my prosthetic margin, really coronally, really so far from the soft tissues, and it represents really important advantages of this material. Because remember that many clinicians think that metal-free approaches are useful only for aesthetic reasons. But metal-free approach is really useful because it allows to us to preserve the tooth structure, and at the same time it allows to me and to us to respect the soft tissues. Look at this case after 10 years of follow-up, for example. We can see how the work is perfectly in function without any complications, and pay attention on the same recession that we observed before the treatment. We can see how we have the same recession. It means that we respect the soft tissues. If we placed, for example, the prosthetic margin inside the sulcus or juxtagingival, probably after 10 years, we observe today a slight recession, a more recession. So it's really important to understand that the metal-free approach is something that allows to us to idealize the aesthetics, but at the same time allows to us to preserve the tooth structure and to respect the biology, to respect the soft tissues. Look, for example, in this small video, the perfect integration of this bridge in the anterior. We can see how the border between the natural root, between the crown, is completely invisible, is completely mimetic. It's impossible to see the difference between the natural root and my crown. I think that today is really crazy to think to prep a root in order to recreate an artificial root. We can absolutely maintain the prosthetic margin so far from the soft tissues. The high-strength ceramics are really useful also when we have to treat dichromic abutment. When we have, for example, tooth that are treated by an endodontic treatment, of course, and when we have an important discoloration. Because in this case, it's important to avoid to use really translucent material, because with the really translucent material we can have the problem that the gray was transmitted through the cupping, and so it can compromise the aesthetic outcome. Finally, the high-strength ceramics are really important when we have to manage situations like this. So full rehabilitations, full arches with big distal cantilever or big pontic areas. And of course, I think that the best option where we can use the high-strength ceramics is the implant-supported prosthesis, where we need the abutments, we need frameworks with an important strength in order to support the rehabilitations. And this is possible not only in case of a single crown, but in case, of course, of partial or in case of complete rehabilitations. Now, I want to stress this aspect, the aspect of the flexural strength, because I'm sure that all of you, all of us, know perfectly that all the materials that the company shows us are classified by the flexural strength. Like if this aspect is the most important and the only one to consider in order to select the right material for each clinical situations. But remember that the flexural strength is an evaluation made in the lab where we take in consideration the option to test some feature with the evaluation that exprime Newton on millimeter squared. So what does it mean? It means that in relation to evaluate perfectly the flexural strength, it's really important also to understand the thickness of the material. So sometimes using a stronger material, what in a minimal thickness, it doesn't mean to have absolutely the strongest solution, because of course the thickness that I can use with this material is absolutely important in order to evaluate the material to use. So the flexural strength is absolutely really important, is really mandatory when we treat patients with this type of solution, like full arch, framework in case of implant, distal cantilever, big pontic areas in the posterior segments. But absolutely, the flexural strength is not so important when we have to treat the anterior segment, when we have to treat the single crown, for example. Because in this case, it's important also to evaluate how I can manage the space for the restorations. And in fact, today, how I will show you after, the topic, an important topic nowadays, is the monolithic approach. The first experience with the metal-free material, in my opinion, it was completely wrong, because we know how in the past, 10 years ago, the companies tried to produce the cupping with the smallest thickness. We start from 0.8 and we arrive also to 0.25. And this approach, it means to use, of course, a layered materials, a layered approach. So we had the coping and we had feldspathic porcelain to put on the top of the coping in order to recreate the aesthetics and in order to recreate, of course, the function. But this approach, in particular in the posterior segment, or in particular in all the clinical situations where we have an important risk profile from a biomechanical point of view, like braxers, like parafunctional patient with parafunctional habits, this approach creates the risk of chipping. Because remember that the feldspathic porcelain that we have on the top of the core is a really brittle material. We speak about simply about 100 megapascal. And in fact, the chipping is a clinical reality that happens in all clinical practice. And the problem, what is the problem? The problem is that in the past, typically we use really thin thickness of the coping, and we put on the top of this thickness 1 kilo of feldspathic porcelain. Look at this case, for example, and look which thickness we use for the coping. Okay, we can use also the zirconia, of course, that is really a strong material. But if we use this material with a thickness of 0.3, is not correct, is not the right thing to do. Because with this minimal thickness, of course, my restoration, my crown, cannot be so strong, cannot withstand to important forces in occlusion and during the bite. Look at this case, for example, another my complication after 6 years. And we can see how I observe an important fracture, but look in how I manage the thickness. 0.4 for the core and 1.4 millimeter for the feldspathic porcelain. This is the reason why I observed this fracture. This is the reason why today is really fashion to speak about monolithic approach, because in this way we avoid to have the combination between two materials and we have only one single material. If the right material, the best material to use with a monolithic approach should have particular features. First of all, the translucency, because it's the only way to achieve a good aesthetics simply with a colored or a painting approach. The third aspect is the strength, because it's important to have a correct strength of the material in order to avoid to have important fracture or to have biomechanical complication. And in the end, the third aspect is the etchability. And really, I'm really a fan of this aspect because it allows to us to be really minimal invasive on our patients. So the two options that today we have are the monolithic lithium disilicate that we can work with press technology or CAD/CAM technology. And the second option is the zirconia that also today can be used with the monolithic approach. So now we are going deeper to each element. What about the translucency? We know how the lithium silicate is a silica-based ceramics, and so absolutely it has a superior translucency. Even if today also the zirconia, thanks to a new modification on this product, also the zirconia really can have a good translucency, but not comparable to the translucency of lithium disilicate. Look at this case, for example, the same patient. In this case, I realized two bridges. One in monolithic lithium disilicate and the second one in monolithic zirconia. And I want to show you, for example, the difference between the two materials. And we can see clearly here how the lithium disilicate is absolutely more translucency respect the zirconia that is too opaque. And also, if we see the result in the mouth during a train, we can see how the natural appearance of the lithium disilicate is absolutely better than the natural appearance of the zirconia. And remember that today we have high translucency zirconia, like this that I show in this slide. But remember that this type of zirconia has a flexural strength of about 600 or 700 megapascal, not 1200 like the traditional zirconia that we use, for example, for abutment or for the framework. So remember that yes, we have a better result in terms of aesthetics, but we go to compromise the flexural strength. And remember that the lithium silicate has 400 megapascal, and this type of zirconia has 650 megapascal. So there is a difference, but it's not too much, like in the past where we have 400 versus 1,200. So what about the strength? The strength is really important. Look at this complication. This is a monolithic crown in Empress 1 with 200 megapascal, and is not so reliable because the flexural strength is not enough. And we know how the flexural strength of lithium silicate ranged from 380 380 and 420, while the flexural strength of zirconia ranges from 650 and 1,200 in relation to the material that I select and in relation to the translucency that I want. Because remember that with the 1,200 zirconia, of course, I have a more opacity respect the 600 and 500 zirconia, of course. And what about the etchability? This is for me really the most important aspect to consider when I select a material in my clinical rehabilitations. Of course, for the lithium silicate it works because it's an etchable material, while in case of zirconia it doesn't work because it's impossible to etch the zirconia. And so with the zirconia, the adhesion, the bonding is not reliable like in case of silica-based ceramics. And what does it mean? It means that with lithium silicate, I can use the bonding and can do minimal invasive preparations without a real retentive preparation, like crown, for example. But they can produce also veneers, tabletop, inlay, onlay. While with zirconia, I'm forced to use this material simply for crowns or bridges. And in my opinion today, that I love to work on enamel, the idea to prep all teeth like a crown is something that it doesn't make sense. This is the reason why, in my opinion, the lithium silicate, like all the etchable materials, are absolutely the go-to solution in terms of modern restorative dentistry. The enamel. The enamel is something of is really important in order to preserve our teeth, in order to achieve predictable, reliable restorations. I want to show you this case. Look here, an old case. Look these two metal crown with 45 years of follow-up. And look what I observe when I remove this crown. I observe untouched teeth, no caries, and no any type of problem. Why? For the material, for the cement? No. Simply because the colleague in the past preserved the enamel, because the enamel is really important in order to preserve the integrity of the tooth and in order also to protect the tooth from the biological complication like the caries, for example. So the first target, the first thing to respect when we prep a tooth is to preserve the enamel. And if we preserve the enamel, the second aspect is, of course, to use adhesion, to use the bonding, because we have the possibility to create a perfect gel, a perfect combination between the enamel and the restorations. Restoration that, of course, it must be produced by an etched porcelain, like silica-based ceramics. In this way, I etch the enamel, I etch the material, and I can obtain a perfect combination between the two components, and I can achieve a reliable solution, a reliable restorations. I want to show you really a crazy case, just to demonstrate to you how really we have to believe on adhesion. Look at this patient, really young patient with the problem of crossbite on the canine, or the lateral canine. She asked me to treat this case from many years, but I refused this treatment because the ideal solution, of course, is the orthodontic therapy. But she refused orthodontic therapy, and I don't remember exactly when, in terms of years, but at one time I decided to treat this patient. in order to satisfy completely her requests. And so, which is my treatment plan? In order to be minimally invasive, in order to respect the tissues, the soft tissues and also the tooth, also the hard tissues. My idea was to do something thanks to the adhesion. Look here, first of all, we have a case of altered passive eruption. So it means that we have to remove these soft tissues, these keratinized, this gingival on the canine, because we have enamel that is under the soft tissue. So I plan also a periodontal therapy, a periodontal surgery. But first of all, like in all my treatment, from the limited treatment to the extensive rehabilitation, I do the mock-up, because the mock-up is something is unpriceless value, because allow to me to give to the patient the opportunity to see the final result before to start with the treatment. And in this case, of course, I'm sure that the result, it works for the patient. But my aim, my topic, it was to evaluate how the patient feels with this tooth in the mouth that is really big. Because before to do definitive result, definitive restorations, in this case, really I want to check if the patient really feels good with this solution. And of course, she felt good, and so I decided to start with my treatment, and so periodontal surgery in order to expose the enamel, and after the complete healing, we decide to do the restorative treatment. And which kind of restorative treatment? Look here. I decided to do really a minimally invasive preparation, a partial preparation of the buccal aspect, just to create like an area where to cement my veneer. Look here the preparation. We can see from the white line how I maintain my margin on the top respect the inferior, the lower teeth. We can see also in this image how is the preparation. And we can see how the incisal portion of the tooth is completely in touch, is completely preserved. And this is my restoration in lithium disilicate. This is the cementation using the rubber dam, really important in order to control perfectly the cementation, the excess of cement, to control the fit of the restoration and also the fit of the margin on the tooth in order to be able to be sure about the integrity of our restoration and to avoid to have infiltration in the future, of course. And this is the situation before the treatment. This is the restorations, look which important thickness, and this is the outcome. So, it's a crazy case, really small one, but just to give you an idea that with adhesion really we can work. And after 7 years, the restoration is still in the mouth, perfectly in function, without any type of complication or without any sign of potential complication. And so, of course, the adhesion is absolutely reliable. And absolutely we have to work with it in order to idealize our treatment and preserve the structure of the tooth that we are going to treat. So the topic is that we work with veneers from 20 years. And from the clinical data, we know that veneers are a reliable solution because we know how after 20 years of follow-up, we have a survival rate of the 83%. And this is absolutely a good value. So the idea is that we have to try to transfer the approach of the veneer to the crown. So we have to transfer the approach from veneer to crown, because today it's possible. It's possible because we have the possibility to work with restorations with really a minimal thickness. And it allows to us to preserve enamel on the buccal portion of the tooth, on the palatal portion, and why not also in the interproximal portion. I want to show you this case, for example. I love this slide because in this slide we have two times of the restorative dentistry. On the first molar we have a monolithic lithium disilicate crown. On the second molar we have a fused gold crown. These two restorations are really distant in terms of years, in terms of times. but are really similar in terms of concept because they maintain enamel and they take in consideration only one material, a monolithic approach. This patient had a gold crown also in the first molar that I removed for biological complication, and so I decided to treat this patient with this new innovative approach because this is what I found when I removed the old crown. And look, it's an untouched tooth with a good portion of enamel, a vital tooth, of course. And so why I have to prep a lot? Why I have to prep again this element? My approach was simply to refine the preparation in order to define perfectly a margin, a slight margin, and I produce a monolithic restoration lithium disilicate with the same thickness of the gold, So 0.6 millimeter on the axial wall and 1 millimeter or 1 millimeter and 2 occlusally. And I cement the crown with an adhesive approach, obtaining this type of result. And my follow-up is of 5 years, simply 5 years, while the other result, the other crown, the gold crown, has a follow-up that is superior to 30 years. But I preserve the vitality of the tooth, I preserve the enamel, and so I'm able really to treat perfectly with a minimal invasive approach this kind of tooth, thanks to the new material and thanks to a right selection of the material in relation to the case that I have to confront. So I want to show you also this evaluation. This is my treatment, one in 2004, the second one in 2008, and the last one in 2012. And I want to show you very quickly how the management of this kind of patients is changed during these years. Look, for example, here the preparation in the upper jaw in 2004, in 8 and 12. And look how today we are really minimal invasive respect 2004 and also respect 2008. Because today we know how it's possible to reduce a lot the invasivity of our preparation. And also concerning the selection of the restorative material is completely different. Because in 2004 I use a layered lithium disilicate in the anterior, layered zirconia in the posterior, a big mistake. In 2008 I use a layered approach anteriorly and a monolithic approach posteriorly with this thickness. So posteriorly I maintain 1.5 millimeter in occlusion and anteriorly I maintain 1.2 millimeters. In the last case, in 2012, the situation is changed again because I maintain in the posterior a monolithic approach with minor thickness. Minor thickness, because if I have enamel, I can also work with the restoration with a thickness of 0.5, 0.6 millimeter in occlusion. It works if I have enamel and if I perform the right cementation with the correct adhesive approach, with the adhesion of course. While in the anterior segment, always a layered approach, in particular when we have patients with an important expectation, but with minimal thickness. We can see how the thickness is 0.8 millimeter. So really, during these years, we can see how we change the materials, we change also how to use these materials, and we change also how we prep the natural dentition, how we prep the teeth. And really, we are in the epoch of the minimal invasive approaches in order to respect the soft tissues, to respect the teeth, maintaining the enamel, obtaining really reliable solutions. The idea to use monolithic approach with silica-based ceramics started with Petra Guess from this in vitro study where she assessed how monolithic lithium silicate crown in full volume, in a full contour, exists until 900 Newton without any fracture. While in case of layered and unlayered zirconia crown, so treated with feldspathic porcelain, simply after 200 Newton, they manifested fracture. Why? Simply because I know that zirconia is stronger than the lithium silicate, is the strongest solution that we can use. But I have to put on the top feldspathic porcelain that is really brittle. It's brittle in terms of material, but it's brittle also in terms of the combination that we can obtain from the material and from the feldspathic and the zirconia, so with the framework. I want to show you this case. A young patient that asked me an aesthetic treatment, and look the X-ray. The situation of the mouth is perfect. It's really an healthy condition. The majority of the teeth maintains the vitality. We have 2 teeth with the endodontic treatment. But anyway, if I want to treat this patient with an aesthetic treatment, it's important for me to take in consideration that it's a young patient. So I have to create a reliable solution in order to don't compromise the integrity of the teeth and to give to the patient really a predictable result that with a good endurance in time. This is the intraoral situation, and we can see how we have problem with the length of the teeth, with the proportion, and of course we have to plan a multidisciplinary approach in order to create the space for my new restorations. In fact, we can see how in this case we plan to change the proportion, to change the length, do 2 millimeters apically, 2 millimeters and 0.5 incisally in order to create the right proportion. And of course, in this case, it's mandatory to perform a mock-up, and it's mandatory, of course, to perform a multidisciplinary approach in order to move all teeth in a buccal direction, in order to create diastema and to have finally the space for our restorations. This is the image, this is the peak after the orthodontic therapy, after more or less 1 year. So now I can continue my treatment with, of course, the periodontal surgery in order to expose the enamel that I have under the soft tissues, because also in this case we have an altered passive eruption. And this is the phase of the surgery where we go to design the new profile of the soft tissues. We can see in dark line the old position of the soft tissues, and we can see in the white line exactly the position of the cement enamel junction. So where I will replace the soft tissues after my surgery. And this is the result after the surgery. So now I'm ready for the prosthetic therapy. And so in this case, I have to idealize the occlusion, I have to idealize the aesthetics. And so the only treatment that we had planned, it was to perform a full mouth rehabilitations in the upper and the lower jaw. And in this case, when we work on at least 1 arch, it's really important always to take into consideration the option to increase the vertical dimension. Because if we increase the vertical dimension, we have the possibility to create a space for the hour restoration, and so we have the possibility to reduce the invasivity of our restorations, of our preparation. In fact, I know, in my experience, I realized that when we treat, for example, both the arches, both the jaws, if we increase the vertical dimension of 4 millimeters anteriorly, we have the possibility to create a space on the second molar of 2 millimeters. It means that in this case we have 1 millimeter for the restoration in the upper jaw and 1 millimeter for the restoration in the lower jaw. Of course, we know that when we have to increase the vertical dimension, it's important before to evaluate several aspects in terms of TMJ, muscles, but anyway, it's an option that is absolutely useful in this case in order to obtain a perfect minimal invasive approaches and to respect the structure of the teeth. So, I want to show you the preparation of this case. Look here. These are the preparation that I perform. And in all these cases, always I don't do the anesthesia, because it doesn't matter. Because I don't arrive in dentin, don't touch the dentin, because my preparation is limited in enamel. And I want to show you I want to compare the upper jaw after and before the preparation. It's really similar. We can see, okay, the cord inside the sulcus, but stop. We open slightly the interproximal area, but we can see how we don't touch, for example, the palatal aspect of the anterior teeth. We maintain the enamel. We maintain the enamel also on the buccal aspects. And so to maintain the enamel, it means to preserve the integrity of the teeth. This is the final restorations by Giancarlo Barducci, and of course in the posterior monolithic approach, in order to beef up our restoration posteriorly, in order to reduce the invasivity of the preparation, and in order to have the reliable solution as much as possible. About the cementation, I'm a fan of adhesion, so I like to use the rubber dam in order to control perfectly the fit of each crowns, of each veneers, of each bridges. And in this way I can really refine perfectly the margin. I can check exactly if I remove completely the excess of cement. And so it's a good thing for the patient, and in particular it's a good thing also for the soft tissues, because in this way it's impossible to have excess of cement that can irritate the soft tissues. One thing that is really difficult to put the rubber dam in prosto. It's difficult if we prep the teeth with the really deep preparation inside the sulcus. But if we maintain our preparation juxtagingival, or why not also extragingival, because we have any reason to place the prosthetic margin, for example, intragingival on the palatal aspect or in the lingual aspect? No. In fact, today really often we do tabletop that stay really distant from the soft tissues, in particular in the lingual and the palatal aspects. And look here in a high magnification of how really we can control perfectly the matching, the gel between the restorations and the teeth, the routines. So these are the restorations on the model, and this is the result that I achieved after the cementation in the upper and in the lower jaw. And look here also which kind of material. Monolithic lithium silicate posteriorly and layered anteriorly, because this is a young patient with high expectation from an aesthetic point of view. This is the frontal evaluation of the upper, and here we have the evaluation in the lower. This is, for example, the phase of the train, where we control, for example, the color, where we control the occlusion. And here we have the final result after the cementation of the lower restorations. Important also the functions, so anterior and lateral guidance. And we can see here how we preserve, from the X-ray evaluation, we can see how we preserve perfectly the vitality of all the teeth, because we maintain the enamel. We don't do anesthesia during the preparation. This is the aesthetic integration in the face of the patient. So really we are able to manage perfectly this complex situation where we had also gummy smile, so we are able to reduce the gummy smile, to change the aesthetics of this patient, maintaining the integrity of all the teeth, and so obtaining absolutely a reliable solution. Remember the case that I showed before with 45 years of follow-up of metal crown cemented with a normal cement, but that after 45 years they allowed to me to get a perfect intouched teeth thanks to the enamel. So this is the baseline, this is the result after 1 year, and this is the result after 2 years, and here we have the evaluation also in an X-ray before and after the treatment. Actually, in the last year, in the last 2 years or 3 years, usually when I treat patient with an high risk of fracture, of chipping, of biomechanical complication due to, for example, the muscle, like for example brachyfacial patient, or due to, for example, parafunctional habits, like bruxism or like clenching patient. Or also due to the occlusion, because remember that the occlusion is like the contest, is like the place where our restoration must be survived for many, many years. So the occlusion, if the occlusion is good, is perfect, probably the restoration can work many, many years. If the occlusion is not perfect, our restoration will be more stressed during the function. And so in all these clinical situations, I think that the idea to beef up our rehabilitation is really a good point. It's really the go-to solution. And this is the reason why today, in many clinical situations, I use a monolithic approach also anteriorly in order to avoid absolutely the risk of chipping. Because today, with the right technique and with a good experience, it's possible to really obtain good result also with the monolithic approach in the aesthetic area. For example, this kind of preparation, really minimal invisible, and these are 4 crowns in monolithic lithium silicate with a follow-up after 5 years. Absolutely, the result, it works. Is not an excellent result, but absolutely is a good result that is enough to satisfy the expectation of the patient. And as always, I like to do like this, to cement my restoration on enamel. We can see how in this case I have enamel also in the margin. So completely my restoration is bounded on enamel. And here we have evaluation during the smile and intraorally. Completely monolithic. Another case, for example, a bad occlusion. Patient that breaks continuously the incisal margin. This is the occlusion. We don't have contact in the anterior segment. So I decide to do crown, but without a preparation on the palatal aspect. Because I have just the space for the crown, thanks to the open bite that I have anteriorly, because the teeth, the upper and the lower teeth, aren't in touch, doesn't touch. And this is the preparation in the buccal aspect, maintaining the enamel. This is the preparation in the palatal aspect, and we can see how I design just a margin and stop, that's it. I remove the undercuts and I maintain, of course, the enamel. Look here the thickness that I use. In some area, the teeth, the restorations had a thickness of 0.2 millimeters, really thin. And look also in this case, the cementation with the rubber dam, maintaining enamel, and with the prosthetic margin on enamel. The best option that we can achieve during restorative dentistry. And this is the final outcome, simply with the monolithic approach. Another case of a monolithic approach, similar to the case that I have just shown you. Minimal invasive preparations in the vestibular portion, and also in this case, this is the result after the cementation and after 5 years of follow-up. So I think that in this way it's possible really to idealize our rehabilitations, in particular from a functional and from the point of view of the reliability. That I think that for many clinical situations it represents really the main target to get. I want to show you another case, a complex rehabilitations with a bad occlusion, parafunctional habit. We can see in fact the important deep bite that we have. We can see also the situation of the lower teeth with important abrasion, erosion. We don't have too much enamel, but anyway we can proceed with the same approach. Look here, the occlusal evaluation in the upper and the lower. We can see the important erosion in the upper jaw, in particular on the anterior teeth from premolar to the central incisors. And the approach it was the same, increase the vertical dimension and to rehabilitate both the arches. And this is the preparation, look here, minimal invasive, of course, without anesthesia, also in this case. And this is the result before and after the treatment, trying to idealize the occlusion and of course also the aesthetics. But remember, with an important strength in occlusion. So the main topic here is to have really a reliable, a strong rehabilitation. The other side, the function, anterior guidance. I want to compare now the lower jaw before and after the preparation, and we can see how really is minimally invisible. And this is the final outcome after the cementation. The same thick in the upper, before and after the preparation, and this is after the cementation. And this is my result after my treatment with a monolithic approach. In this case, monolithic anteriorly and posteriorly, lithium disilicate. In this way, I'm sure that for this patient, I use the best solution that I could. Another case, this patient came to my care because she wanted to treat simply the lower teeth because she didn't like the appearance that are really worn, and so she asked me my idea, my treatment. Look here, we have an important extrusion of the lower teeth thanks to the erosion, thanks to the abrasion. And this patient stayed also to another colleague, and the colleague proposed to do endo on these anterior teeth with the periodontal surgery in order to recreate a perfect aesthetics, a perfect appearance. But it's not the right solution. First of all, because in my opinion, if we endo this treat, so we treat with this element with an endodontic therapy, and then we do periodontal surgery with the apical reposition flap, it means, in my opinion, that this element probably in the next years, I don't know if after 3, 4, 5 or 8 years, but probably will fail because are really compromised teeth. And secondly, about the occlusion, really not an ideal situation because we have also in this case a deep bite, we have a cross bite posteriorly, and theoretically in this case the best option would be to treat both the arches. But the patient was really rigid and she wanted to treat simply the lower jaw because she did the full crown in the upper just 3 years ago. So my treatment, my idea was to do restorative, of course, but not in this way. So not to obtain the space for the restorations apically with the periodontal surgery and with the endodontic treatment. My approach was restorative, thinking to move the teeth in a coronal position. Because remember that also the patient request was to treat the anterior for aesthetic reason. And for aesthetic reason, these teeth required to move the incisal edge coronally in order to have a good exposure of these teeth at rest and during the smiling and during the phonetics. And so to do this approach is mandatory to proceed with an increase of the vertical dimension. The same thing that we did in the first case. In this case is simply one arch, and so I increase 2 millimeters anteriorly from canine to canine, and automatically I have 1 millimeter in the posterior segments. The increase of the vertical dimension in all these cases where we have also a minimal overjet, it's something of really important because allowed to me not only to obtain the space for the restorations but posteriorly, but also allowed to me to increase the overjet and so to idealize the anterior and lateral guidance. Because we know that the first movement is basically a rotation, and so it means that if we increase the vertical dimension, automatically we move the incisal edge, the buccal surface of the lower teeth in the back direction and in the apical direction. So move down and back. And this is really important to idealize the occlusion and so also the function. Okay, so also in this case, we increase the vertical dimension of 2 millimeters anteriorly from canine to canine, and automatically in this way we obtain the space for the restoration in the anterior segment. Because remember that 2 millimeters anteriorly, it means 1 millimeter posteriorly. This is something that I observe in the 95% of my rehabilitations. So this is the wax-up that the dental clinician produced thanks to my indication that always I give to the lab in order to produce the perfect wax-up. And now I want to show you another thing that for me is really mandatory in our prosthetic approach, that is the mock-up. Look at this video, for example. We can see how always in this clinical situation where I perform an increase of the vertical dimension, always I do the mock-up because the wax-up is in addition. And so I can create the volume of the wax-up. I can create the volume of what the dental clinician did in the lab in the mouth of the patient. And in this way I have the possibility to test the aesthetics but also the function. So we use this tray, this transparent tray and this transparent silicone using to stamp the new volume in the mouth. The resin that we use is the Luxatemp. This is really an excellent material for this approach because we can use it in several colors, and so it's possible to obtain also good aesthetics. In this case, for example, I performed the approach in 3 different steps. First of all, the anterior and then the posterior segment. This is a normal video that I do during my practice in my office, so it's normal sometimes to find some bubbles, but it doesn't matter because with some flow composite we can really correct, we can manage this defect in order to create the new anatomy, the new shape. And it's really important after this kind of work to be sure that the patient is able to use the microbrush in the interproximal area in order to maintain their oral hygiene, because I love to leave this mock-up in the mouth of the patient for at least 1 month. Because in this way, in 1 month we can test not only the aesthetics, but we can test the phonetics, we can test the function, we can test the vertical dimension, we can test to don't have any type of problem at the TMJ or at the muscles. Really important thing to do. So this is the result after the second steps, and this is the result after the third one. So now I have exactly the wax-up in the mouth of the patient, and so I can test everything. How you have seen in this case, when you want to maintain the wax-up in the mouth for a period superior to 1 month, it's important to etch the surface of the enamel in order to create a perfect bonding between the composite and between the surface. And this is the result of the mock-up after 40 days. So the patient has tested perfectly the new occlusion, the new situations. And now I can start with my treatment with the preparation of the teeth. And look how I prep the teeth. Really minimal invisible. I maintain the enamel. The occlusal portion is untouched because I obtain the space for the restoration simply thanks to the increase of the vertical dimension. Look, the evaluation on the occlusal aspect. In the mesial aspect on the second premolar, I remove probably a carrier. I don't remember exactly. This is on the reason why I create this important hole. But we can see how the occlusal surface is absolutely untouched. And remember that the cementation is an adhesive cementation, so if we have the possibility to use the rubber dam is absolutely the best option, the best solution. In this case we produce veneers, crown, tabletop, and this is the result after the cementation, a monolithic restoration. So I know that if I use a layered approach I can obtain a better result, I know. But in this case I want a good result from an aesthetic point of view, but particularly I want a reliable solution. I want a strong solution for my patient that he has a bad occlusion, not ideal occlusion, and in the same time he has also parafunctional habit, and in fact always to my patient that I treat with this approach I deliver also a night guard, an appliance to wear during the night in order to preserve the restoration. And here we can see the result before and after the treatment. Look here. The location of the prosthetic margin is absolutely extragingival. Wow, but we can see how it's really difficult to find it because the blending between the surface of the root of the surface of the tooth and the surface of my restoration is really perfect. This is the occlusal evaluation, and we can see how in this area that I marked with the circle, I produce tabletop, and we can see how the margin is really coronal. It's not a crown, it's not an overlay, and I know how to call it because it's a restoration that works in the occlusal portion and in the vestibular portion. Stop. And this is the X-ray evaluation, just to see how I maintain perfectly the vitality of all the teeth, maintaining the integrity from the structural point of view, and so with the maintaining and obtaining, of course, a good reliability. And this is the outcome before. This is the peaks before and after the treatment, and we can see how also with the simple monolithic approach we can obtain a good integration of our restorations. All this my experience, I have collect all my experience with this approach, and I have published this article in 2014. This article takes into consideration 860 restorations in lithium silicate placed in the anterior and the posterior segment with this approach, so with the minimal invasive approach with minimal thickness. And the 32% of the patients that I treat were patients with severe parafunctional habits. And the result, my result, was that success rate, not the survival, but the success rate ranged from 95 to 100%. With patients that the 33% has severe parafunctional habit. So it's absolutely a good result. It's an absolutely reliable solution to use when we have the possibility to maintain an enamel and we have the possibility to restore, to manage the rehabilitation with single crown. What about bridges? What about bridges? In particular, what about the anterior bridges? So today, when we have to treat bridges in the anterior, it's normal that we have to assess several parameters, like the span of bridge, how much is it, the aesthetic demands of the patient, and of course the biomechanical risk of the patient. Remember the muscle, the bruxism, the parafunctional habits. And in relation to this aspect, we can select this type of solution. Now I want to show you a solution in monolithic lithium silicate versus a solution in monolithic zirconia, just to show you the difference in terms of translucency. In terms of course, translucency, remember that this zirconia that I show you is the zirconia with the highest translucency that today we have at disposal in the market, an HT zirconia from Japan. And look also the difference in weight. The zirconia is really dense material. This is the reason why the weight is like the double of the lithium silicate, 1 gram versus 3.3. And this is the result with the lithium and the zirconia. The natural appearance is absolutely superior in case of lithium silicate. What about the posterior bridges? We have to do the same evaluation, the same considerations. So we have to assess the span of bridge, the aesthetic demands, and the biomechanical risk for the patient. And in case of posterior, we have more options. But honestly, I think that the best one are this one that I marked with the green B. Remember that when we work with the layered zirconia, we know how really often we can have the problem with the chipping of the porcelain on the top. Because remember that I spoke in the first part of the lecture, the feldspathic porcelain is really brittle. And really often also the bonding between the ceramics and the framework is not so reliable. And so this is the reason why we can have cohesive or adhesive chipping. Look at this article, 10 years follow-up with the zirconia restorations, specifically with the unlayered zirconia restoration. And we can see how the incidence of chipping is at 32%. And also really important to assess how the chipping is more present in case of bridges with more than 4 or 5 units bridges. So absolutely, if we use the monolithic approach anteriorly, why not to use the monolithic approaches posteriorly in case of bridges? Because absolutely it's something that can work from aesthetical and functional point of view. The easiest option is the monolithic zirconia, because today we can manage the translucency with the zirconia, obtaining a satisfactory result. This is, for example, a bridge in the posterior, in the upper jaw, simply colored, without any layered material. This is a bridge, a zirconia of 650 megapascal, and here we can see exactly the translucency that we can achieve. Remember that monolithic zirconia is something that today is yet experimental, because we don't have important clinical data about this solution. We know that the anatomic cortex zirconia produce less antagonist to wear than the feldspathic veneers porcelain. The important thing is that this zirconia must be really polished, and the best way to polish the zirconia is using the mechanical instruments. But the topic is that from in vitro study we know that after the evaluation in vitro, all the restoration in the antagonist dentition with enamel showed crack after this evaluation. What does it mean? It means that if we have a monolithic zirconia and as antagonist we have a natural dentition, from this in vitro study, this in vitro study showed how all the antagonist that was opposite to monolithic zirconia manifest crack. And so it means it depends on absolutely the rigidity of the zirconia that is really, really high. And it is an element that we have to consider in our clinical practice in order to select the right material. But remember that it is an in vitro study. And about the clinical relevance of this aspect, it's impossible to have some evaluation, some perfect evaluation. So we don't have a clinical relevance. We have simply a data from the lab. So it means that it's not something that is absolutely real. Other option could be the combination between zirconia and monolithic lithium disilicate, like in this case, where I have a patient with a high expectation from an aesthetic point of view, even if we speak about the posterior segments. And in this case, we use the framework in zirconia to give a good support to the bridge. And then we produce a second framework in monolithic lithium disilicate to cement on the framework on zirconia, so to cement on the first framework in order to recreate the occlusion and to recreate the normal shape, the function of these bridges. And in this case, we have 100 and 2000 megapascal like framework material for the framework material, and we have 400 megapascal in case for the lithium disilicate, and so we have a strength in occlusion of 400 megapascal. The combination between the two materials can work with an adhesive combination, so with an adhesive cement, and we can see here the restoration after the pairing approach, after the combination between them, zirconia inside and lithium disilicate in superficial, and here we can see the border between the zirconia and the lithium disilicate, and absolutely the match between the two materials is perfect. This is for an example, and this is what we can achieve with this kind of result. On the second molar, I want the prosthetic margin juxtagingival, because from an aesthetic point of view in this area it doesn't matter, but I want to check perfectly the fit of my bridge. Another option is the combination between zirconia and lithium disilicate, but lithium disilicate obtained by the CAD-CAM technology. So it's metasilicate that is combined with the zirconia thanks to a crystallization process in the oven. And in this way, thanks to a ceramics called Crystal Connect, it's possible to combine perfectly these two materials. Another option could be to combine the monolithic lithium disilicate to metal framework, because sometimes really rare situation, fortunately, we don't have the possibility to produce a zirconia framework, like in this case, where we have abutment on implants, all the implants that the patient had, and this abutment had really a sharp design. So with a sharp design, it's better to avoid to use zirconia. And if I go to prep again this abutment, I have the risk to reduce the vertical height and so to don't have enough retention for my bridge. So in this case, I produce the restoration in this way. Metal framework and then monolithic lithium disilicate cemented on the top thanks to the adhesion, thanks to adhesive cementation. So an adhesive combination, of course, also in this case. Metal and monolithic lithium disilicate. Press, of course. I use 99% press lithium disilicate because it's more easy to manage, is more precise. We can obtain better anatomic surface, better design, respect the CAD/CAM one. And this is the result of my treatment. This is before, of course, and this is after my treatment. And here we have an X-ray evaluation of this case. So in this my lecture, I wanted to introduce this topic. It's really an important topic that it could need days to speak about this topic, speaking about crown, bridges, and all kinds of rehabilitations. But remember that if our topic must be the integration from an aesthetics and functional and biological point of view, remember that I have a motto. And my motto is, first of all, respect the biology. Thinking minimal invasive and working with adhesion. In this way, really, we can have the possibility to preserve the structure of the teeth, to respect the biology, to respect the soft tissues, and obtain prosthetic outcome with a good aesthetics, with excellent aesthetics, an excellent function, and in particular, with a good reliability. Thank you for your kind attention.
For more education programs, visit the Guide Institute at www.guidedental.com.